Welcome to Heartbeats from Lifelong Learning and our series on hyperlipidemia and atherosclerotic cardiovascular diseases, or ASCVD. This program is made possible by an educational grant from Novartis. However, the content has been created and directed by a volunteer planning committee independent of the grantor. The recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association, American Stroke Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the AHA-ASA. The AHA-ASA does not endorse any product or device. In this episode, you'll learn about effective implementation of quality improvement initiatives and team-based care, and how they're essential to overcoming treatment barriers, mitigating clinical inertia, and optimizing cardiovascular risk management. This episode highlights contemporary strategies to identify individuals at elevated risk for cardiovascular disease through the integration of novel biomarkers, including lipoprotein (a), and validated cardiovascular risk assessment tools, such as the Pooled Cohort Equations, or PCE, prevent, and coronary artery calcium scoring. Learning how these approaches provide a framework for tailoring preventative and therapeutic strategies, enabling timely intensification of treatment, and ultimately improving clinical outcomes across diverse patient populations. After listening to this podcast, we hope you will be better able to implement individualized patient-centered treatment plans for ASCVD patients with persistently elevated LDL cholesterol levels, and analyze quality improvement strategies and team-based care models to overcome treatment barriers and reduce clinical inertia. I'm Cheryl Chow, professor of pharmacy practice at Western University of Health Sciences in Pomona, California, and I'm here with three guest speakers, and I'll have them provide some self-introductions.
Hi, yes, so my name is Nathan Wong. I'm cardiovascular epidemiologist and professor and director of the Heart Disease Prevention Program at the Mary and Steve Len Cardiovascular Division at the University of California, Irvine, and also co-director of our new Center for Global Cardiometabolic Health and Nutrition, and a past president of the American Society for Preventive Cardiology.
I'm Emily N. Andaya. I'm a primary care physician, but I also hold a certification in clinical lipidology, obesity medicine, and lifestyle medicine. I am the medical director of our cardiometabolic program at MHP in Shelbyville, Indiana, and I'm also the medical director of our cardiometabolic and liver health center.
Thank you. Nihar?
Thanks, Cheryl. It's great to be with you guys. Nihar Desai. I'm an associate professor of medicine and vice chief for the section of cardiovascular medicine at Yale University School of Medicine in New Haven, Connecticut. It's really great to be with you guys.
Thank you all. So I think we're ready to get started. Nihar, can you help set the stage for our discussion here? What is implementation science and why is it relevant as part of our series on cardiovascular disease prevention in general and the management of hypercholesterolemia in particular?
Yeah, thanks so much, Cheryl. I think that's a really great place to start. I think implementation science is really getting at the gap between evidence and practice. I think we've known for a long time about the importance of LDL cholesterol. The science is overwhelming and it's clear. We've had a vast number of clinical trials. We've had professional society guidelines that have then summarized, all of that evidence. And yet we know, unfortunately, despite the 2018 AHA-ACC multi-society guidelines and even the 2022 expert consensus decision pathway, that when you look at all of the evidence out there, too many of our patients are not getting to the LDL goals that those professional society recommendations have advocated for. And so there's a lot of risk that our patients are carrying. That risk could be mitigated if we better tailored our practice and more closely aligned our practice to the evidence and the recommendations that are out there. And implementation science then really is the study of how do you bridge that gap between evidence and practice. And so, it's great to be here with Emily and Nathan. They've been leaders, kind of in this space, have done, such important work. But maybe just to frame out our discussion a little bit, maybe some sobering statistics, just to kind of put this the problem into better, definition. It's sort of reported in the literature that fewer than 1 in 3 patients following a myocardial infarction will have their LDL cholesterol assessed. More than 1 in 5 are not prescribed a high-intensity statin following an MI. Fewer than half of the patients with diabetes will receive statin therapy. And about 50% of those who are initially prescribed a statin will discontinue it within 12 months. And when you take all of that together, probably the summary statistic that we all really want to work around, and what is the problem, at least around LDL cholesterol, it's that about 1 in 3 patients will actually achieve the goal LDL that's outlined in the professional societies and in the guidelines. And so I think that brings us to the focus of our discussion. What is the cause of this disconnect or dissociation where the science is so clear, the evidence is so clear, the guidelines are so clear, and yet clinical practice lags so far behind?
Yeah, no, I agree. And Nihar, you talked about the gap between the evidence and the practice with respect to LDL cholesterol. So, in what ways do you imagine this being even more difficult with LP little a?
Oh, that's a really interesting question, Cheryl. So yeah, I will say, um, you know, I think we've seen this kind of evidence treatment or evidence practice gap for LDL cholesterol, and that's after many, many decades of education around LDL cholesterol, everyone having accessibility, to that test, everyone feeling very comfortable with interpreting those results, all of the trials, all of the practice guidelines that we've had. And yet still today, contemporary practice would suggest that there's that sort of gap for LDL cholesterol. Now, if we switch gears and think about that in the context of lipoprotein little a, I think the challenge will be even more substantial. I think there's a substantial amount of education that needs to be done to really get our provider community, our colleagues, whether that's primary care to endocrinology to lipidology and cardiology, and everyone who's touching these patients to really understand the biology, the epidemiology of lipoprotein little a. How do you do the testing for it? How do you interpret the results? And then hopefully we'll have some, therapies and interventions to try and mitigate the risk that comes, with elevations in LPA. But if we thought that was a difficult task to do for LDL cholesterol, where we have all of this science, an expanding armamentarium of therapies to lower LDL, and yet we still seem to be falling short, I think that really highlights just how big the problem is and just how significant the barrier will be for LP little a. And I think this is an area where, we desperately need implementation science efforts. And I'm absolutely delighted, obviously, to have Emily and Nathan, because again, they've been real leaders in this space. And I think they've got some really exciting work, to share in that context.
Yeah, absolutely. Let me shift gears and ask Nathan. I understand that you and your colleagues have implemented electronic health record messaging to improve lipid management in your institution. So, can you tell us a little bit more about that?
Well, first of all, it's certainly been great to learn from the work of Nihar and others, and he's been a real inspiration for some of our efforts. So, first of all, we know that many patients including those at high risk, are not regularly tested for lipids. Such as people with ASCVD, amazingly, less than half of them have had a lipid profile in the past year, and many are not reaching targets. So we felt that we needed to improve these statistics. And several years ago, we first implemented a best practice advisory sent to physicians who had patients who had a recent LDL test result of 190 milligram per deciliter or higher, suggesting that they further evaluate their patient for FH and to consider LDL lowering treatment. And we've written up these results, which I'm now pleased to say was this accepted for publication and will be out in the next month or so, maybe sooner online. And this project showed significant increases in both statin and non-statin use following this BPA, as well as more than 80 milligram per deciliter reductions in LDL cholesterol in those who had pre-post measures of LDL. More recently, a few years ago, we implemented best practice advisories. First, actually, a health maintenance alert for LDL testing in people with ASCVD. And along with that, BPAs for high intensity statin use in people with ASCVD, as well as considering further non-statin use in those that are already on high intensity statins but are not at recommended targets of 70, and for those at very high risk as defined by our guidelines, below 55. We were also the first, I understand, to implement an Lp(a) best practice advisory for patients with a personal or family history of ASCVD, aortic stenosis, familial hypercholesterolemia, or an LDL of 190 plus. And we have seen increases in Lp(a) testing at our institution. We're currently working on gathering the data to look at what long-term effects this effort may have had on perhaps promoting more intensified lipid management, as well as LDL changes, since, as we know, we don't yet have pharmacotherapies for Lp(a), and the main recommendation that most societies have for individuals with elevated levels is to comprehensively reduce their cardiovascular risk, whether it's through more intensive lipid lowering as well as other risk factor modifications.
Well, that's exciting work. So I wanted to ask you, given the recent cholesterol management guidelines and recommendations, how do you think the risk scores such as PCE and PREVENT, as well as coronary calcium testing, inform us on who should be treated to reduce their ASCVD risks? I understand, Nathan, you also have some interest and expertise in this area.
Yeah, well, no, it's a pleasure to talk about how coronary calcium can be incorporated into our prevention efforts. It's a topic that's been of great interest it's a topic that's been of great interest to me since doing some of the early pioneering work in this going back more than 30 years. So first of all, we know that in our 2018 cholesterol management guidelines, we use the Pooled Cohort Risk Equation, and perhaps the updated guidelines we anticipate will come out next year will incorporate perhaps different cut points using the PREVENT risk score. But at least with the PCE, what they point out is that if you have a 10-year ASCVD risk estimate of less than 5%, there's an emphasis on lifestyle management, whereas if you have a score of 20% or greater, it's a definite indication for consideration of statin therapy to reduce LDL by at least 50%. But if you're in that borderline intermediate range between 5 to 20%, remember that they recommend we first evaluate for a wide range of risk enhancing factors to further inform the treatment decision, such as the extent of premature family history, diabetes, hypertension, and female-specific risk factors such as gestational diabetes and preeclampsia. All these things can increase a woman's risk, as well as certain biomarkers such as hsCRP or Lp(a). And then based on these measures, we can further decide whether to initiate or intensify therapy. But there is also the option to use coronary calcium score, particularly if the decision is still unclear after consideration of these factors. And in people that may have a calcium score of 0, there is a recommendation in the guideline to consider withholding or delaying treatment unless they have diabetes, heavy cigarette smoking, or a premature family history of ASCVD. But if you have a calcium score of 100 or greater, then there's a definite indication of treatment, because we know that these individuals will derive net clinical benefit, such as from statin treatment. Whereas if your calcium score is 0, and we all know the power of 0 concept, right? A 0 calcium score is actually the best predictor of not dying, and your risk going out in studies have shown up to 15 years or more of not having a cardiac event or not dying in general is very, very low. So that's important to understand. Now, to take this one step further, we recently have realized that a calcium score may be more actionable if used as a diagnostic tool for staging of disease. And in this paper that I was recently involved, led by David Marin, that came out in JACC Advances, we stage disease according to the extent of CAC, ranging from stage 0 in those without CAC to stage 4 if someone had a CAC score of 1,000 or greater. And for each of these stages, we have recommendations for the intensity of treatment as well as LDL targets based on CAC, such as we recommend both statin and non-statin treatment to reach an LDL target of less than 70 when the CAC score is 100 to 299, but below 55 if the score is 300 or greater, and when someone is classified as stage 3 or stage 4 if their score is 1,000 or greater. I might finally just add a comment regarding this, that we are in a new era of what we call opportunistic testing. And there was a recent American Heart Association statement on opportunistic testing for coronary calcium, led by Randy Foraker, that I was pleased to be part of. And we know that there's more than 19 million adults getting CT scans, often for non-cardiac reasons, such as lung cancer screening, but they may never have their cardiovascular risk assessed. But we now have AI technology that can assess CAC quite accurately from such scans, providing an opportunity for them to know about their risk and to manage it before clinical events occur. And in fact, there's now technology where we can look at a host of other measures, such as cardiac chamber sizes and even liver fat, that can further assess for other cardiometabolic risk, as well as other types of cardiac events, such as heart failure and atrial fibrillation, all from a CT scan that is done for other non-cardiac reasons. So we don't have to necessarily rescan an individual, but we're using existing data. So I think the future is very bright in terms of utilizing these new technologies to better assess patients' cardiovascular risk.
Wonderful. Thank you for sharing the advances with respect to integrating CAC into risk assessment. Nihar mentioned earlier that there was a lot of potential for research with respect to Lp(a), and it really is a hot topic right now and an underappreciated risk factor for ASCVD. So Nathan, I understand you've also done some work in this area, and how do you think that you might be able to incorporate this into risk assessment for ASCVD? Can you share a little bit more about this work that you're doing?
Yeah, so as a matter of background, there have been some recommendations in the past, such as the AHA 2022 statement on lipoprotein A, which considered that we could use an equation and data on the risk of Lp(a) derived from the UK Biobank that was, of course, done in individuals in the United Kingdom to basically add an amount of risk associated with the Lp(a) to the existing pooled cohort risk score. So what we did recently was to create an Lp(a) risk score in the US population, and we used a real-world cohort electronic health database that was provided by the American Heart Association as part of their lipoprotein A data challenge competition, which we were pleased to win first place in. And what we did is we created a risk score from basically adding Lp(a) to the pooled cohort risk equation from this EHR database, and we externally validated it in 4 US prospective cardiovascular disease cohorts. And we showed a 21% net reclassification improvement in risk category from the addition of Lp(a). Now, if we take this case study involving a Black male age 65 with other risk factors, as shown on this slide, the 10-year risk without Lp(a) was 17.9%, but this increased to 24.2% when his Lp(a) value was 80 milligram per deciliter or higher. And in this case, such an individual at this level of risk would be definitely indicated for statin therapy. So this is how the Lp(a), knowing the Lp(a) value and how it impacts on their baseline risk can further drive patient management.
Yeah, and certainly risk scores could improve population health by identifying those that could benefit from therapeutic intervention in a timelier manner. However, there are many barriers to care when applying science to real-world settings. So I'm going to bring Emily in here. What are some of the most important barriers you've observed in your practice as primary care physician?
Thank you so much, Cheryl. Thank you for that question. First, I would like to thank Nihar and Nathan. I'm a big fan. um, so we have a lot of barriers. There's no simple answer to that question. And all of them are actually pretty important. And that's the reason why we have all those gaps that Dr. Nihar mentioned. But one of the most important thing there that I noticed in primary care is the fragmentation of care. So in many cases, patients see multiple healthcare providers, and it is easy to have miscommunications. For example, a patient can be admitted for a heart attack and may follow up appropriately with a cardiologist and then end up in the primary care clinic. And primary care, like me, may say cholesterol control per cardiology. And cardiologist may say cholesterol control per lipid clinic. But then the patient may not end up in the lipid clinic and can end up not optimally controlled, or their cholesterol, no one's following up with their cholesterol, and end up with having another cardiovascular event due to that therapeutic inertia. So that's one. And another significant barrier is the knowledge gap between both the healthcare providers and the patients. Many providers, especially here in primary care, may not be fully up to date on the latest clinical guidelines for managing LDL and ASCVD. And as a result, they might not use the most effective therapies or may even hesitate to aggressively treat high risk patients, even if they're in front of them, such as those who require high intensity statins or newer treatments like PCSK9 inhibitors. And this knowledge gap can also include the knowledge about Lp(a) and the screening recommendations. But providers always get blamed if patients' cholesterol is not controlled. And oh, it's always the primary care's fault. It's always our fault. But there are also patients who don't fully understand the importance of managing LDL cholesterol, even if we prescribe the medications. And the problem there is health literacy is often very low in patients. Patients do not realize how crucial it is to maintain cholesterol control over long term. So they probably think, oh, I've been taking this for a year. Maybe I'm done. I'm fine. So they do not appreciate the risk of not following their prescribed treatment plans. Just like what Nathan emphasized on the previous session, there's also the negative perception of statins among patients. Misinformation and lack of understanding of the benefits lead to poor medication compliance. That's actually a big problem. And with Lp(a), patients rarely know about Lp(a). They don't know anything about that or its implications. And if their providers do not recommend testing, it is unlikely that patients is going to ask or pursue testing. And even if, let's say, providers are aware and trying to do everything that they can to give the best care to the patient, access to medication is another problem. Medications, especially the newer lipid-lowering drugs, they can be expensive. They're very, very effective in attaining our goal, but they can be expensive, especially for patients without comprehensive insurance coverage. And even when the medications are covered, sometimes high copays can limit the access. So lastly, access to testing is important in managing cholesterols, but many patients, particularly those in rural healthcare settings and underserved areas like our area, can sometimes face difficulties in getting regular lipid testing. And it's hard to assess whether a patient is on track or not with their treatment if we don't have the testing. And we know that lipid testing is readily available. It's already a struggle, just like what what Nihar mentioned. It's already a struggle. How much more for screening for Lp(a)? It is not widely available. That will be more challenging. And also, many providers are simply not aware of importance of Lp(a), or they don't feel confident unto when or how to test it. Guidelines vary in the recommendations, but all of us here know that NLA, National Lipid Association, already recommended screening all patients once in their lifetime, but many are not aware of that yet. And even cardiologists, even if they're aware of that, they're hesitant in ordering that because they think, what else are we going to do about it? And secondly, cost and insurance issues can limit the access. testing may not be covered, or not all labs have that testing, or sometimes it can require out-of-pocket payment, which can be a deterrent for patients. And lack of widely available treatments for elevated Lp(a) lead many clinicians to question the utility of testing. And in a busy clinical setting like primary care, we're the first line, but we need to know that more immediate priorities like managing hypertension, diabetes, and cholesterol comes first before the LP(a) testing, because we know if it's abnormal, it's going to add to our workflow.
Yeah, so Emily, you mentioned several very important barriers, and one of which is the gap in communication between healthcare professionals. It's very important. As you know, the AHA has constructed a framework that addresses cardiovascular, kidney, metabolic health using patient-centered focus and interdisciplinary team-based care. This framework from 2023, the presidential advisory from the AHA clearly offers actionable guidance and the importance of early screening, risk detection, and tailored interventions, especially for individuals with a confluence of factors. So, do you think that this framework could be used to overcome gaps in care that you've observed when managing lipids, for example?
Absolutely. It's actually one of the best tool that I'm using in primary care right now. And thanks to you, I saw your name in there. You're one of the authors there. So thank you for that. But yes, it is actually a very powerful tool, especially when you apply it to the lipid management. And the CKM construct help providers identify patients at high risk for ASCVD. And that leads them to look for those patients who are high risk and further risk stratify them. And also, it can guide the intensity of the management. The construct emphasizes using not only statins, they also mentioned about non-statin treatments such as ezetimibe or PCSK9 inhibitors to help patients achieve LDL lowering goal. And what's powerful about this model is that it provides a unified guideline that can be followed by both specialists and primary care providers like me, ensuring the consistent and coordinated care. Can you just imagine? When all healthcare professionals are aligned and empowered to act, we can begin to overcome the challenge of therapeutic inertia. Another important recommendation of this advisory report is the emphasis on the team-based care. This includes engaging clinical pharmacists, that's your territory,
It is.
nurses, case managers, and other healthcare professionals to support medication adherence and patient education, involving a broader care team that can significantly improve patient engagement and compliance with therapy, especially in those with multiple comorbidities. If you can just imagine, we have so many gaps because no one is following this patient. So if we put more support there, then patients are less likely to fall on those gaps.
Yeah, absolutely. And, it takes a village to raise a child, and it takes a village to also address the complexities of patient care. So, another question on an institutional level, are there any specific quality improvement programs and resources that audience members here might find useful?
Yes, one of them is American Heart Association's Track Change Control Cholesterol Program. It is a nationwide quality initiative that helps institutions or medical practices implement guideline-directed LDL management or cholesterol management strategies. By participating, these institutions can measure their performance. They can identify their gaps and they can improve the patient outcomes through data driven action. And that is also where registry works very, very well. Another key initiative is the Cardiometabolic Center Alliance, or CMCA. It is a collaborative network aimed at integrating cardiovascular, renal, and metabolic care across the systems. CMCA provides tools, pathways, and metrics to help institutions design a comprehensive care model that prioritizes prevention, early intervention, and aggressive risk factor control, including LDL, of course. And the good news is that CMCA is now a part of American Heart Association. And lastly, in terms of screening, especially advanced lipid markers like Lp(a), we know we need broader access. We know that. While insurance coverage is still evolving, organizations like Heart Foundation and Care Access are stepping in to provide free lipid and Lp(a) screenings in communities. They also offer educational resources, helping patients better understand their cardiovascular risk and take in an active role in their health.
So in your own practice, have you utilized any of these resources?
All of it. So yes, I practice in a primary care rural healthcare setting, and we have early on identified where we're lacking, and we worked on how we can improve those gaps. So we used as many resources as we can. We enrolled in the CCC program of the American Heart Association, and we partnered with CMCA as well. And because of that, last year, it's actually our fourth year in getting the Gold Award, the highest award in cholesterol management of our high risk patients. And having that patient registry helped us risk stratify our patients and identify those who need more aggressive treatment, thus overcoming that therapeutic inertia. There are lots of resources available to us. We just need to use them appropriately.
Yeah, that's great information. And so for audience members, we will provide the links and references to these resources in the vodcast attachments. I wanted everyone to know that. So in closing, I just wanted to ask the group for some initial thoughts about our future direction. So where are we going from here? And how can we partner with policymakers, payers, and institutions to support these healthcare initiatives? It's very important. Any
Well,
thoughts?
yeah, well, I guess one point that I might make is that we really need to bring back performance measures, such as those defined by HEDIS, NCQA, or CMS, which will really better hold our healthcare systems and their providers accountable, and ideally tied us into reimbursement. So if such a requirements were tied into reimbursement, such as for hospitals to reach certain metrics on LDL testing, particularly in our higher risk patients, or even perhaps reach certain targets for LDL cholesterol. Now that we have much more effective therapies available, and we know that combination lipid therapy is seldom used, we would get better numbers. And and I might also add that there are certain institutions I know that, for example, provide bonuses for their physicians to achieve certain targets, such as 70% of their patients being on recommended therapies for heart failure or ASCVD. So we've had these evidence-based guidelines for years, and now newer effective therapies, but their implementation has been suboptimal. And absolutely, now is the time that we more proactively implement strategies such as these to improve care and outcomes for our patients.
Thank you. I think people would respond very favorably to new incentives for sure. In closing, I just want to thank all of you for sharing your insights and also for participating in this Heartbeats from Lifelong Learning. To get additional information and to claim credit, please visit learn.heart.org. Thank you.